We're right at noon, so I'm going to introduce today's speaker. I'm really delighted to introduce Dr. Suzanne Bell, who joins us from the Bloomberg School of Public Health at Johns Hopkins University, where she is Associate Professor of Population, Family, and Reproductive Health. I know myself. So she's a demographer working to improve understanding of fertility and related behaviors at the population level and to identify factors that contribute to disparities in reproductive health. And specifically, her work focuses on the demographic, work focuses on patterns of induced abortion, contraceptive use, and infertility. Her published work on the demographic effects of abortion bans in the United States, which we'll be hearing about today, has appeared in JAMA and JAMA Pediatrics and has received extensive media coverage. And she also has a very impressive record of demographic data collection and research on fertility and reproductive health in sub-Saharan Africa. I feel like if you're interested to learn more about demographic data collection, methods to combine administrative data sources, how to collaborate across disciplines effectively, or how to conduct and present very timely policy relevant research, then I encourage you to speak with Suzanne while she's visiting with us. But for now, I'll turn things over to her.
Thank you for that lovely introduction. You really sold me. I hope I live up to those expectations. But I'm delighted to be here today. Thank you all for having me. Thank you for inviting me into your home last night. I was delighted to attend the Demography Pop Center gathering yesterday. And I am going to be talking about my work on the impacts of abortion bans that have been imposed in the US in recent years. And I want to start by acknowledging my incredible colleagues on this work, in particular, Alison Gemmel, who's my MPI on the R01 that funded this work, and a related grant from the Society of Family Planning. But we have a fabulous interdisciplinary team that has made all of this work possible. So as I'm sure all of you in the room are aware, the US abortion policy landscape has undergone unprecedented shifts in recent years, starting with Texas in 2021, which in September of that year passed Senate Bill 8. And that essentially eliminated abortion access beyond approximately 6 weeks of gestation. And at the time, it was the most restrictive abortion policy in the country. And in the following June, on June 24th, which incidentally is my birthday, the Supreme Court's Dobbs decision eliminated all federal protections for abortion and essentially sent that decision to litigate abortion back to the states. Currently, 12 states ban abortion completely. 4 more ban it at 6-week gestation, and 3 more pre-viability, which is about 22 weeks gestation. But there's been a lot of churn across the states in the intervening years since the Dobbs decision. And so thinking about kind of how this all ultimately might relate to additional births or pregnancy outcomes, we have a number of factors that you all may hypothesize or know were related to access to abortion and abortion rates pre and post Dobbs. These are kind of many socioeconomic factors that influence these outcomes. But then we had a whole host of new factors that we assumed were going to influence the likelihood of a pregnancy continued and ended in a live birth, or for pregnancy outcomes post Dobbs. Ultimately, we think that there are 3 primary mechanisms that may link abortion bans to greater births and for pregnancy outcomes. One is just the increase in births that might occur as a result of an inability to overcome barriers to abortion access in the states that imposed bans, which for maternal outcomes, we know is associated with much higher risk of maternal morbidity and mortality than a safe abortion performed during pregnancy. Additionally, we have shifts in the composition of these excess births that are occurring towards populations that are experiencing greater structural disadvantages that have higher rates of poor pregnancy outcomes. And then there have been many anecdotal cases that you've probably seen reported in the news media around denial of evidence-based life-saving care to pregnant people, for whom continuing the pregnancy is a great risk of their health. And so ultimately, what we've seen and what we know about the impacts of these abortion bans, I'll start first with what we know about the impacts on ultimately the service delivery environment, which has had some significant shifts in intervening years. Initially, you'll see here the Dobbs decision in the red dashed line. There was a decline in the number of abortions being provided nationally in the US, and that continued until about March of 2023. We've actually seen more abortions being provided nationally since that time period. But simultaneous to these overall trends, we're seeing significant shifts in the service delivery environment. For instance, now 1 in 5 abortions involve interstate travel. This is compared to 1 in 10 prior to Dobbs. So here's an example of shifts in population, shifts in where those abortions are being obtained. For Texas specifically, Guttmacher has a great resource on their website if you want to explore by specific state, but this really unprecedented shift in where people are obtaining their abortion. We also see a shift in the mode of service delivery. Now, 20% of abortions are being provided via telehealth in the US. These are data from the Society of Family Planning's We Count project. That's up from about 5% prior to the Dobbs decision. And roughly half are being provided under shield laws in states that protect abortion, where providers are providing telehealth medication abortion to people residing in states with bans. Simultaneous to this, there's been an increase in self-managed medication abortion documented by many researchers. And then nationally, we have seen this overall shift in increase, but some of that is being driven by increased access and the availability of abortion to residents of states that have abortion protected in those states. And so this isn't necessarily telling us how many people were ultimately unable to obtain a needed abortion in states that have imposed bans, or the potential unequal burden of these bans on residents of those states that have imposed them. And so what do we know about the impact of these decisions? So we had our first evidence was from colleagues Dench et al. That looked at the first 6 months post-Dobbs and saw about a 2.3% increase in the live birth rate in the states that imposed bans. And some of these additional births, we were seeing anecdotal evidence that they may have been a result of forced continuation of pregnancies for whom the pregnancy was due. They had a fatal fetal anomaly diagnosed during pregnancy, and the pregnant person was unable to obtain a needed termination. This was the case for Samantha Casiano in Texas, who describes the experience of being forced to continue a doomed pregnancy as torture. And so there's this piece that we were also interested in understanding, and the initial evidence that came out, just looking nationally at trends in infant mortality, showed about a 7% increase in infant mortality shortly after, starting in July of 2022. There was no comparison group, but this gave us an initial support of this hypothesis that we might expect to see infant mortality increasing as we suspected. And then there's been a fair amount of anecdotal evidence around the impacts of abortion bans on maternal health and maternal death. ProPublica has done some incredible investigative reporting of this, focusing specifically in Texas and Georgia. And we see these highlighting these, potentially devastating consequences of these policies on pregnant people and their families. But we really need systematic review at a population level to understand the population impact empirically on these populations, and to the extent that it might be inequitably impacting certain populations. To date, prior to our work, we only had kind of simulations, this type of reporting, but lacking really that empirical research to tell us what's happening at a population level. And then we were particularly interested in the heterogeneous impacts of these abortion bans. Differences in pre-Dobbs abortion rates and infant and maternal outcomes across subpopulations led us to suspect we would expect to see inequitable impacts of these bans. Prior to Dobbs, non-Hispanic Black pregnant individuals, people who are unmarried, individuals living below the poverty line had 2 to 3 times the rates of abortion as their less structurally disadvantaged counterparts. And so there was a greater reliance, more potential for those subpopulations to be negatively impacted by these bans. You have disparities that existed prior to those bans in people's ability to overcome barriers to abortion that were well documented in the literature from studies like the Turnaway study and others. And then you have state-specific characteristics that might interact with these policies being imposed, where states' demographic compositions and their social and economic policies, are shaping access to reproductive health care and childbearing choices. And we wanted to understand these key sources of heterogeneity within and across states. So what did we know prior to our work around the potential heterogeneous impacts? There were a couple studies, I alluded to the Dench paper earlier, that started to look at some variation in the impact of abortion bans, but limited characteristics that they were able to examine. Only one prior study had looked at disparities or heterogeneity and impact by race ethnicity with regard to infant mortality. only in Texas. And then really we only had simulations around the potential impacts on maternal and pregnancy-related mortality, specifically in the Stevenson paper. So there were some significant gaps that we were looking to address with regard to fertility, no real examination of subgroups that more directly address structural and resource constraints. That was something that we thought, even in the absence of income data, was really important to understand. That Dench paper had not looked at joint estimation of variation in the impacts within and across states. It was looking overall at all states that imposed a ban, and no direct comparison of those impacts across groups. They were kind of separate models for each of those subpopulations, and it was for a limited exposure period. Infant mortality, it was just this overall trend analysis, no causal assessment, and limited evidence of any heterogeneity in those impacts. And then, like I said, no empirical evidence on the maternal health impacts. And so that was what we were seeking to assess in our study, to estimate the impact of US abortion bans on fertility, infant mortality, and maternal and pregnancy-associated mortality through the end of 2023 overall, but then also digging into those inequities, potential inequities by subgroup. So for data and methods, I'm sure many of you will be familiar with these data sources. We used vital statistics data from the National Center for Health Statistics from all 50 states and the District of Columbia for 2012 through 2023. The live birth and infant death analysis, we actually started before the restricted individual level data were available. So we were relying on CDC Wonder aggregate data. Talk more about the implications of that if people are interested. Live births was our first outcome of interest. We were looking at this bi-monthly. I can talk about the temporality decisions if people are interested. These are just counts of live births, which we ultimately measured as rates. Infant deaths, these are deaths of a live born infant up to 1 year post-birth or post-delivery. Maternal deaths, we were measuring quarterly and looking at counts of deaths during pregnancy or within 42 days of the end due to causes related to or directly aggravated by the pregnancy. And then pregnancy-associated deaths, these are deaths during the pregnancy or within 1 year of the end of the pregnancy. So this is any cause in that time frame. And then for the denominator, with regard to live births, the population counts come from the census data. So our outcomes, we ultimately converted into rates to deal with the underlying differences in population size, looking at fertility rate, infant mortality rate, maternal mortality rate, and pregnancy-associated mortality rate as defined here. And then the exposure is that we're looking at specifically is the imposition of a 6-week or complete abortion ban. So there are some states that impose, for instance, a 12-week ban or 18-week ban. We are not considering those states exposed. People were still, in many cases, able to obtain an abortion there. Happy to talk more about that decision, but that's ultimately how we operationalize exposure to an abortion ban in our study. We then lagged the start of the exposure period to account for gestation in determining the first birth cohorts or corresponding infant or maternal pregnancy associated deaths that we consider to be exposed. So for many of the analyses and individual states that roughly correspond to about January 2023, Texas, because they imposed their 6-week ban in SB8 almost an entire year prior in September of 2021. Their exposure start period is nearly a year earlier for all of these analyses, and we take that into account in our staggered adoption of the analysis. Pregnancy-associated mortality, because that exposure period goes all the way up to 1 year postpartum, and thinking about the mechanisms, that exposure period is actually not starting until June of 2023. We're doing a lot of Lexis diagrams to think about where we have the least amount of potential misclassification, because we don't have linked data between the death certificate and the exact timing of the birth and gestation. And so it gets a little tricky in trying to operationalize which births or deaths were exposed. And that's something that we down the line could potentially return to when those linked data become available through vital statistics. And just to confirm, the states that we are looking at are 14 states. They're listed there at the bottom. I know the font is very small, but happy to list those out if you're curious. So on to our analytic approach, starting with some of the statistical challenges that we had in thinking about how we're going to inform this counterfactual and our attempts at addressing these challenges. So for anyone who is familiar with the birth data in the US or fertility rates, you know that there's a lot of heterogeneity across states. Each line here represents a state. The red are those that later went on to impose an abortion ban, one of the 14 exposed states in our study. These are counts of live births from 2016 through nearly the end of 2023. And you see some important patterns that we're going to need to account for. There's overall, there's seasonality, this autocorrelation. We have secular trends, fertility is declining overall. We have COVID-19 right before the imposition of this policy, and huge variation in the number of births across states that we all need to account for in the model. And then thinking about kind of precision and how we're estimating impacts, there's a lot of variation in group size across states. This is, for instance, infant deaths, comparing South Dakota to Texas. You also have you have additional variation across subgroups and across states. And then there's even more pronounced variation at the subgroup level within states. That this feeds into our ultimate analytic decision around how to model this. And then I also want to highlight some particularly challenging methodological considerations as it relates to the measurement of the maternal health outcomes that we're interested in. Births in infants that we measure that very well in the US in our vital statistics data. Those data are highly valid, and we're certain that we're capturing really the universe of these outcomes. That's not necessarily the case for maternal and pregnancy associated mortality. First, maternal and pregnancy associated deaths are very rare. So right from the get-go, we're dealing with power issues. And disaggregating any of these outcomes by state and subgroup obviously is going to present substantial challenges for causal inference. Second, we have the potential for maternal and pregnancy associated mortality data misclassification. These data suffer from well-documented misclassifications, both under ascertainment and over ascertainment. For example, we have false negatives from comparison of the death certificate data to maternal mortality review committees actually going into these data and actually, finding someone who was pregnant of reproductive age, death, they were pregnant but not denoted as such on the birth certificate. And so we don't capture that person in our routine data collection. And then you have false positives, which are I'd say potentially most common with the pregnancy checkbox, which if you might be familiar with that was something added to our birth certificates data and death certificate data in the last couple decades, kind of gradually. But there are many cases, particularly for older birthing people, where the death certificate box is checked for this person was pregnant within the last 42 days or 1 year, when in fact, when they go and investigate, they were not. And so you have this issue of, most concerning would be differential misclassification across these states. And so this is another major concern that we're having to think about in the background and understanding and interpreting our data. And then you have the lingering COVID-19 effects. There was a huge increase in maternal mortality, in particular with the strain that was most common around 2021. I'm blanking, I think that might have been the Delta variant. And we discovered in our data, quite differential by whether the state subsequently went on to ban an abortion or did not. And so concerns about non-parallel trends. What we ultimately decided to do was to exclude deaths that we see on the death certificate is attributable to COVID-19 using the ICD-10 codes. So all of these present real methodological challenges, in particular for this maternal health analysis. So lots of issues. Ultimately, what we came to do is use a causal inference model that allows for this staggered adoption that I talked about, in particular, the Texas versus the post-Dobbs abortion bans. We see violation of the parallel trends assumption. And so we turned to a factor model that allows for, it loosens that or relaxes that parallel trends assumption in the pre-policy period, which I can talk a little more about. To appropriately model count outcomes, we are doing a Poisson model, accounting for those denominators in the offset there to account for heterogeneity in population size. Because we're using CDC publicly available data initially for the fertility and infant mortality data, we had a lot of missingness. They suppressed counts below 10 in the CDC Wonder data, if any of you have used that. So we actually then an additional complexity in that analysis was to impute those periods where we had a suppressed count. And then a lot of different and noisy estimates across those states and subgroups across time. And so we ultimately chose to take this factor model approach, modeling count data in a Poisson model with imputation, and hierarchical modeling with partial pooling for this Bayesian model. And ultimately, this is an overdispersed Poisson latent factor model. The key assumption of these methods is that the outcome is well approximated by a small number of latent factors, as opposed to a two-way fixed effects, which is essentially a special case of a latent factor model where the factor model has 0 factors. And so the parallel trends assumption here that state and time are additive in a kind of standard two-way fixed effects or diff and diff. Here, we're allowing for a little bit of interaction between state and time, which allows us to loosen that assumption of parallel trends in the pre-policy period that we saw was violated. We did a lot of examination of model fit by state, looking at data quality concerns, in particular with the maternal outcomes, where we know there's more data quality issues. And then we're modeling each of these by state and by within state by subgroup to look at these impacts, exploiting that heterogeneity that we were particularly interested in. And ultimately, I don't think I said it, but the outcomes in states without the bans for the entire study period, as well as the pre-policy outcomes in states that later imposed a ban, are informing that counterfactual for the states that imposed bans in that post-policy period. So quickly showing you some of the model checks we did. We did, standard kind of gap plots. This is Texas, for instance, the number of infant deaths, to see how the model was fitting in the pre-policy period and what we're seeing post imposition. We did extensive placebo and time analyses, in particular for our fertility analysis, where we reran our analysis for, it was 21 placebo times, where we were just shifting the exposure period back during times where we would expect there to be no impact because the policy was not in effect. So we want to see essentially no major shift in those abortion ban states in the pre-abortion ban period. And we conducted similar but fewer placebo and time checks for our other analyses as well, for our other outcomes. This, as a flash forward to some of our results, is, for instance, the birth analysis, those placebo and time checks. You see all of the placebos are the grays. The dotted line is the policy, start of the exposure, and then the post period is to the right of the 0. And our actual realized exposure is the red line. And then you see some of the placebos where some of them do increase a little bit, but are generally centered around 0 in the post imposition period. So I think these, provide further evidence of the robustness of our main effects, which I will present shortly. Lastly, before we get to the results, one thing that we were particularly concerned about is this issue of spillover, which in our causal model was a key assumption, that we wouldn't have spillover in the states that did not impose a ban. So the outcomes that we see in those states could be used to inform our counterfactual assumption or counterfactual of what would have happened in the absence of the bans in the states that did impose them. The challenge is that some of these states saw huge increases in the number of abortions being provided in those states, and in particular, increases in the accessibility, even in those states, through increased telehealth medication abortion, which could change potentially the fertility rates of residents of those states. And so using their live birth outcomes or their birth outcomes as a reference point for what we might have expected in the absence could have been problematic. So what we did for some robustness checks was to remove the states where we saw the largest increase in the resident abortion rate, or those where we saw from, for instance, SFPE count data, the biggest surges in abortions after the Dobbs decision. And our robustness checks results were essentially the same, but slightly attenuated, even when we removed those states that we were the most concerned about there being spillover. Okay, so if you're all still with me now, I've set up the analysis and we're on to the results, starting with fertility. So this figure represents the bi-monthly fertility rates for states without bans in the gray, the states with bans excluding Texas in the red, and then Texas in yellow with a simple linear smoother superimposed to elucidate these trends over the study period. You start to see potentially Texas, it's increasing even in the lead up to a little bit and then staying higher post bans. Maybe in the red, it just stays more flat, whereas we're actually seeing a decrease in fertility in the states that didn't impose a ban. This was kind of our initial look at the data before we then jumped into the model to actually kind of empirically assess whether what we're potentially seeing is in fact meaningfully different. And overall, what we conclude is an estimated 1.7% increase in the fertility rate above what would have been expected in the absence of these bans. This is equivalent to more than 22,000 additional births, or one additional birth per 1,000 reproductive aged females in these states. We see here the impact was somewhat larger among females under 35 compared to those aged 35 to 44. By education, we found meaningful variation based on college degree completion, in particular, where individuals with only a high school diploma had a 2.4% increase in fertility above expectation, and those with only some college experienced an estimated 1.6% increase. There was an estimated 2.4% increase in the fertility rate above what would have been expected in the absence of these bans for those with lower incomes who would qualify for Medicaid, whose birth was paid for by Medicaid during their pregnancy. And then in contrast, those with births that would not have qualified and were not paid for by Medicaid, we see no increase. Estimated differences in the fertility rate were larger for unmarried individuals compared to married. And there was strong evidence of larger effects among racially minoritized individuals than for non-Hispanic white individuals, with more than double the percent increase among Hispanic, non-Hispanic, Black, and other racial and ethnic groups compared to non-Hispanic white individuals. And when we exclude Texas, which imposed their ban, if you recall, nearly a year prior to dogs, we estimate in the remaining 13 states only a 1% increase in the fertility rate above expectation, equivalent to about 5,600 additional births above what would have been expected. So roughly 75% of the excess births that we calculated occurred after these bans occurred specifically in Texas. And I can talk more about why that is in the Q&A, what I think that is. And then the state-specific estimated effects in the other 13 states ranged from 0.3% in Missouri to about 1.4% in Kentucky. And regionally, we estimate approximately a twofold higher increase in fertility rate in southern states compared to non-southern states. So the impact is really concentrated in those southern states, which I think, you know, if you think back to that figure of the states with the abortion bans that I had on an earlier slide, you know, I think that makes a lot of sense given their contiguously located in concentrated area in the South. So making it particularly hard for residents of those states to access care. And then we also estimated state-specific subgroup effects for individual states. Those are all in the appendix of the paper, which I'll share the link to at the end. But broadly speaking, the patterns were quite similar across subgroups within individual states. So you're not meant to be able to see and interpret this from where you're seated, but just a flag that these analyses are also at the state level. And those estimates are consistently larger in those southern states compared to non-southern states. And then we wanted to try and understand what are some of the factors that might be explaining heterogeneity in the state-specific impacts across states. You know, that there was a big range from 1.4. So we did some simple kind of post hoc calculations, and here I've just pulled out the R squares, but there's actually a lot of the heterogeneity in the state-specific estimates that are explained by individual sociodemographic factors, these compositional differences across states. So variation in education across states explains 85% of the variability in the estimated effects of these abortion bans on fertility. Race and ethnicity explains 73%. These are separate. So a lot of what's driving this is perhaps compositional shifts in the population of the state that imposed bans. Other factors that we know from other literature or suspect are things like places like Texas, where distance is a huge factor. And so being able to access abortion care in a facility, should you choose, as opposed to telehealth, it's a lot harder to access that care in another state than if you're living in a small state not far from many surrounding states that offer care. Moving on to our results for the infant mortality analysis. Here we have a similar figure representing the biannual infant mortality rates for those same three categories as the fertility figure. Again, potentially some diverging trends across these groups compared to the states without bans, but I think a little harder to decipher, which is where the model comes into play. So on to our overall effect estimates. Overall, we estimate a 5.6% increase in the infant mortality rate above expectation, or 0.3 additional infant deaths per 1,000 live births. This is equivalent to 478 excess infant deaths. The estimated effects were largest for non-Hispanic Black individuals, or infants specifically, who experienced on average an 11% increase in the infant mortality rate above what would have been expected in the absence of these bans in these 14 states. Compared to a 5.1% increase among non-Hispanic white infants in these same states. We didn't really find any meaningful variation by timing of death, comparing the neonatal period, those first 28 days, compared to the neonatal period, the subsequent 11 months. However, we estimate more than a twofold higher increase in the infant mortality rate due to congenital anomalies or birth defects compared to deaths due to any other cause at 10.9% versus 4.2%. Again, Texas had an outside influence on overall results. They experienced a 9.4% increase in the infant mortality rate above expectation. The remaining 13 states estimated 2.2% increase. Consequently, about 80% of those excess deaths that I alluded to, or around 500, 80% of those occurred in Texas specifically. And other states' estimates ranged widely. And when we zoom in specifically on the subpopulation where we were seeing a disproportionate impact, we see here among non-Hispanic Black infants, when we look at these state-specific estimates, the estimated impacts are consistently positive and higher in all of these states compared to the overall effect estimates, ranging from 6.4% in Missouri to 18.2% in Kentucky. And then our last set of outcomes are those for maternal and pregnancy-associated mortality. So this figure is there's a little more happening than the prior ones. I'll walk you through that. These are those same three categories of states, including and excluding deaths denoted as due to COVID. So COVID-19 is marked on the death certificate as an underlying cause of death. So the dashed marks are the overall number of overall maternal mortality rate, including those deaths. Whereas we decided, given how you can see how differential that COVID impact was on maternal death in states in gray that did not impose a ban compared to states that did. This was a much larger violation of the parallel trends assumption than we felt comfortable just plugging away our model. And so we removed those deaths entirely from the analysis. So the solid lines are ultimately the patterns that we're looking at and thinking about our analytic sample of maternal mortality. And I also want to flag an aim of this paper was also to assess data quality, given a priori concerns that we had about this. And we can only really identify things that seem really egregious as a potential issue. There's likely more issues that we couldn't, but even just a visual inspection of state-specific model diagnostics identified some issues, particularly in Alabama, where we see in the 6 months following the start of the exposure period, significantly fewer deaths than we had seen in any of the years prior by a good margin, and potentially some issues similarly in Georgia for the maternal mortality data. There's nothing we can do about that. That's just to say there's a large caveat on all of these findings, given the data quality concerns that we see and that other research has documented. And we have a similar figure for pregnancy-associated mortality, which, as a reminder, is up to 1 year post the end of the pregnancy due to any cause. And we see similar patterns as we did for the maternal mortality rates. And efforts to remove that differential impact of COVID-19 on deaths appear somewhat successful, but perhaps insufficient. With us, you can still see a bit of an increase in mortality in 2021, not fully eliminated when we remove those COVID-19 deaths. Maybe you have other thoughts on how we could have handled this this issue, but for any demographic population level work that we're doing that involves COVID in the immediate pre-policy period, you're going to have to figure out and how to contend with that. So overall, for maternal mortality, we see estimates are highly uncertain. Again, this is really rare event, about 700 annually, and centered around no change. Perhaps some evidence of something happening in Texas here. And then when we look at pregnancy-associated mortality, again, a lot of uncertainty. But here, using those data that exclude COVID-19, so we have even fewer deaths. But these model estimates suggest as much as an 8% increase in pregnancy-associated mortality rates above what would have been expected in the absence of these bans, again, in these 14 states. That's equivalent to about 59 excess pregnancy-associated deaths. The 95% credible interval does slightly overlap the zero, the null. And this is also about 4.6 excess pregnancy-associated deaths per 100,000 live births. And then when we try to look by race and ethnicity, it suggests perhaps the relative increases are comparable here. But one thing that I think is important to think about in how these bans are perhaps exacerbating existing disparities, when you take into account the significantly higher baseline rates of pregnancy-associated mortality among non-Hispanic Black individuals in particular, a roughly similar relative increase of around 8, similar to what you see with non-Hispanic white, is associated with 10.3 excess pregnancy-associated deaths compared to 4.6, so more than double the absolute impact, which for all of these analyses, we were looking at both relative and absolute increases, which I think sometimes can tell a different story and helps to incorporate those baseline differences. And this is equivalent to about 21 excess pregnancy-associated deaths. But again, lots of uncertainty, heavily caveated given all of the data quality concerns. Okay, I will briefly walk through. Yeah, we're in good shape. Findings and some concluding thoughts, implications, limitations, etc. So for fertility, I think we provide some strong evidence that birth rates increased above expectation in these states with bans, about 1.7%. Our back of the envelope calculations based on how many abortions we might have expected in those states based on abortion rates prior to these bans suggest that about 10% of expected abortions ultimately went on to result in a live birth. So depending on your perspective, 90% did ultimately terminate a pregnancy, whether that's good or bad. I'd say from a public health perspective, given our other outcomes, that's good. Slightly smaller than prior abortion ban studies, so smaller than that Dench study and smaller than what we found in our earlier work looking just at the live birth impacts in Texas following SB 8. We estimated about a 3% increase in Texas. And these are actually pretty similar in magnitude of recent population-wide events. So the COVID-19 birth rebound was about 1.4%. I think around the recession, a 1 point change in the unemployment rate was associated with about a 1.7% decrease or 1.3% decrease. And so, thinking from a demographic perspective, these numbers might sound small, but actually at a population level, it takes a big shock to see this size magnitude impact on fertility at a population level. And the largest impacts, as you might have expected, are among those experiencing the greatest structural disadvantages. And this is consistent across states, with most of this impact being driven by Texas. For infant mortality, overall, again, an estimated increase of about 5.6%. Double the impact among non-Hispanic Black infants and larger relative increases among congenital deaths. And again, most of this impact occurring in Texas. And then for our maternal outcomes, we thought it was really important to approach this research question of what is the potential impact on maternal and pregnancy associated mortality, because everyone was asking it, all of the journalists were interested in it, and we thought this might be our best chance of understanding empirically at a population level what it could be, even if the answer is we don't know, and that's more or less our results for the maternal mortality. You know, these study findings, I think, should be interpreted with caution, given the significant data quality concerns that have been documented and detected in our analysis. But I think there is some pretty consistent suggested evidence of something happening with regard to pregnancy-associated mortality increases. We may be picking that up just because we have more power to do so. But we didn't see anything for maternal mortality. Again, significantly underpowered for this analysis, and our post hoc power calculation suggests that based on our credible intervals, we would have only been able to detect a significant increase if it was an 11% increase in maternal mortality above expectation. That's huge. That would be devastating. So I think this really highlights the limits of what can be empirically measured at the population level for rare outcomes like maternal death. But we thought this is nonetheless an important contribution to the literature. But this work has a number of limitations, some of which I've already highlighted. This issue of spillover, mainly an issue for fertility concern. We did our best to try and assuage people's concerns in that regard. Imperfect, but nonetheless, our results remained robust to our adjustments. For the fertility and infant mortality analysis, we were using provisional aggregate data. So these are not conception cohort analyses. There's potential for misclassification there. Similarly, potential misclassification because we don't have linked birth death data. Something that we're really interested in re-examining now that we have these individual level restricted NCHS data is to go back and look at intersectionality. Obviously, people are these sources of structural disadvantage and oppression are not singular. People can have multiple sources of oppression that are influencing their fertility and pregnancy outcomes, and we didn't have the ability to do that. We didn't have any joint probabilities, and so if people have thoughts or are doing work on intersectionality, we'd love input on how to think about modeling that in a thoughtful manner. These are still just proxy income measures in the fertility analysis, education, insurance. We don't have income data that is, I think, more than what prior analyses have done, but still not ideal. Infant mortality and maternal mortality is really rare, low power. That's not something we can change per se, but we are cognizant of that and have those post hoc power calculations to kind of contextualize our findings. Data quality concerns I've mentioned several times. We can really only identify the most egregious issues, but we think that we know that there are more concerns than that. And the COVID-19 correction that we did specific to the maternal mortality analysis, I think was imperfect, but is a way of trying to disentangle in that pre-policy period the issue there of very non-parallel trends. And then lastly, this issue of misclassification of deaths for maternal, not anything we can avoid unless moving forward, we start to invest more in measuring this better in the US, which would be great. And then lastly, some or second to last, I guess, our lessons learned. I think all of our analysis showed that it's really important to test the sensitivity of results to the inclusion exclusion of Texas. Texas is very large. It's a large distance for people to travel to access abortion out of care. They imposed their ban nearly a year earlier. And for people who are familiar with abortion provision in the US, Texas, even though it was always a hostile abortion providing state, actually had a lot of providers and had about 58,000 abortions being provided annually to residents of Texas prior to these bans. And so there was a lot of potential for impact here. Some states like North Dakota had one abortion provider. Missouri had one abortion provider. North Dakota didn't even impose a ban, although they did close their facility. So there's a lot less potential for impact in a state like Missouri that, if you recall, had the lowest overall fertility impact of 0.3. Very few people were actually receiving an abortion in that state prior to Dobbs. So those sorts of like contextual understandings, in particular with regard to Texas, I think should inform people's analyses and interpretation of those findings. Again, testing the sensitivity to spillover effects was important, I think, for people in the field who were skeptical that they would see any impact because of what we were seeing nationally, at least in the latter half of 2023, and more recently with regard to increases in overall number of abortions being provided. Staggered adoption is tricky, even among the 13 states other than Texas. They didn't all impose a ban immediately after Dobbs. Some had trigger bans, some were enjoined, some took months to impose. So you can't just use some of these off-the-shelf methods to say, this is when the exposure started in these states. And that we were able to do that with this Bayesian kind of bespoke model that our statistical colleagues developed. Parallel trends assumption is violated. So perhaps some of these off-the-shelf methods are not a good option, a viable option for these analyses. Need to address the COVID shock. And then lastly, implications. Very important to contextualize these findings and thinking about population health and equity. Overall, it's clear from our research that many pregnant people in states that impose bans were forced to continue unwanted or unsafe pregnancies to term. And for these pregnancies, we know from prior research out of the Turnaway study, if you're familiar with it, and a whole body of other rich research that have been done prior to Dobbs, that there are profound health, social, and economic consequences of being unable to obtain a needed abortion. And the variability and the impacts of these abortion bans across states suggests that there are state-specific and contextual factors that may present additional barriers for individuals seeking abortion care across the US. And for our subgroup analysis, it's really apparent that those experiencing the greatest structural disadvantages are disproportionately being impacted by these abortion bans. And lastly, while our work thus far has focused on the effects of abortion bans on mortality for the non-fertility outcomes, we think this is really just the tip of the iceberg. Our future work is looking to examine infant morbidity and maternal morbidity outcomes associated with these bans, using, in the case of severe maternal morbidity, some hospitalization discharge claims data, given more data quality concerns with the maternal outcomes if we were to use the birth and death certificate data. So with that, I'll just flag that our fertility and infant mortality papers have been published. There are very large appendices for people who want to know all the nitty-gritty of our methods and our models. The maternal mortality and pregnancy associated mortality paper is under review, but hopefully will one day be published. And I want to thank and acknowledge our funders, National Institute of Child Health and Development. And hopefully this work will continue to be funded by the NIH. So with that, thank you. And I look forward to your questions and comments.
Suzanne?
I have a question about the services landscape, potentially spillover effects. So how would a pregnant person in Texas learn about telemedicine services available in Kansas? Presumably you might talk about flying to the States. It's mostly telemedicine. So what's that landscape look like?
Yeah, so interestingly, actually, a lot of what Guttmacher is capturing is in-facility brick and mortar abortions being provided. People are traveling overnight in cars, they're taking buses, they're flying, mostly driving. But for the telemedicine piece, I think there's been a real effort to publicize the availability of these services and self-managed medication abortion sources for legitimate pill purchases and things of that nature. There's also always been a real host of resources online for people that are Googling or searching for abortion providers that can help people navigate where to access care either in person or virtually. Find an abortion.com or .org is one, Plan C. So there's all of these websites that if you are searching for it are going to show up in the top of your queue. And there has been some interesting work of people looking at Google searches over time, and they actually have since made those data not available. So they didn't want people trying to exploit that data for not great purposes. But yes, it's a very rich and very varied kind of information landscape around abortion. Some not legitimate sources are also at the top of the queue. So people, I think, rely on a lot of cases, and there's kind of social network literature. There's just a lot of people rely on friends and family members, people they know who have accessed care, trusted sources of health information, et cetera, to try and find legitimate resources. I will say that some of the policies, like in Texas and Oklahoma, where there's this like vigilante component, where people who in any way support or aid in the getting a person an abortion, has probably influenced some of people's ability to access information from their social network because they don't want to implicate people, or they're afraid they might get turned in. People have been turned in by partners. So it's a strange dynamic in terms of thinking about how accessing care for this one reproductive health service is becoming very siloed and unique compared to basically any other healthcare access.
Hi, I'm curious if you think that the trends in Texas having been 1 year earlier influenced any of the other states where there might have been a possibility of people knowing that an abortion ban was coming?
Yeah, absolutely. I think in the coverage and a lot of the kind of grassroots work from civil society organizations and reproductive justice organizations really tried to get the word out about these resources that I've been alluding to in terms of finding an abortion provider, in terms of medication abortion pills to self-manage or to access via telehealth. And so I think had all of these states imposed an abortion ban around the same time, you might have seen a more substantial population level impact on fertility and health than had you not had Texas a year prior and kind of the writing on the wall with the Dobbs decision, given the court's composition. And also, if you recall, I think it was in May or the end of April, there was actually a leak of the decision. And so people were also probably preparing in anticipation of the June decision. Yeah.
So 2 questions. First, do you expect that you have some issues with like underreporting? So for example, you just said that Texas had a lot of abortions and then they just banned, right? So I expect that there is like a spillover effect for people that can actually go to another state, but maybe you have some kind of underreporting of people that are doing abortion in the black market. And I think this would impact both denominator and numerator, right? So this is one question. The second question is like, I honestly, I don't understand the method. I mean, I've never seen this, so this is also coming from ignorance, but I was just wondering, what is the extent of treatment actually for these women, right? Like, is this, I'm just thinking that I don't know what are the big changes in abortion in each of these states, but maybe a ban is not actually a ban because it was actually so hard to actually have an abortion that it is not a ban at all. So when you have this as a treatment, I was just wondering if we can do something in terms of dosage, or as you're talking also about staggering, maybe there is some kind of like timely effect, right? And I don't know if you're putting like the places that have the policy are also in the control group and then they shift to the treatment. But I feel like this could be something that could impact your, even underestimating your, it makes sense. Or not?
I think I got your second question. I'll start with the first one because that one's easier to answer. So actually a lot of my work outside of this project is trying to improve measurement of abortion incidence, abortion safety, and equities in those outcomes in settings where abortion is legally restrictive, largely sub-Saharan Africa, on surveys where we know underreporting is a serious issue. Even in the US prior to the Dobbs decision, where it was legal across the US, we know from some research that less than 50% of abortions are reported on the National Survey of Family Growth. When you compare those survey reports to facility-based, like brick and mortar data that we have, the Guttmacher Institute would collect abortion provider census data, and this was pre-telemedicine becoming broadly. So we know those data on surveys are poor. I was excited for the first time in my career to get to bypass the abortion underreporting issue altogether and go straight to an outcome after the abortion occurred or didn't occur. So when we're looking at live births, when we're looking at infant mortality, whether or not someone is willing to report that they provided abortion or received an abortion is not relevant, because all we're looking at ultimately is what's happening at the population level in terms of the number of live births. And our model is informed by that outcome. We're looking at outcomes over time, pre and post ban in states that imposed and did not impose these bans. So there are Herculean efforts of groups trying to measure the extent of abortions actually being provided in brick and mortar facilities through telehealth under SHIELD laws. We don't actually use that information to inform the model. We're looking at these outcomes post-abortion. So kind of skipping that issue altogether, but it is a huge issue. And for people wanting to do abortion research, like the NSFG data, they say basically don't use the abortion data because it is so biased. Yet people still do. The other question was about, I think, people like states going in and out or kind of coming late into the.
Side is like, are you having shifts from like a state is treated and was in the control and now it's in the treatment? This is the first question. Then the second question was the extent of the treatment. Like, is it actually a ban for the woman in the margin or is it extensive? Because I imagine in Texas is extensive margin treatment, right? You cannot do this, but maybe other states was more in the margin.
Yeah.
So I think this would be.
Yeah, so for the second question, I mean, this isn't really an implementation science analysis. There may be providers illegally providing abortions outside the scope of the law. There are some people still obtaining abortions in those states because they fit into one of the very narrow exceptions around health of the pregnant person or it's a doomed pregnancy with some fetal anomaly that is listed in their law. So there are some exceptions. We know there are some legal and probably some not legal abortions being provided in those states. But by and large, abortions have stopped, especially for, pregnancies that are not for a health-related issue. So we don't necessarily get into that per se. We are doing a policy analysis and just is the policy in effect and ostensibly being implemented as designed or not? And beyond that, that might explain some of the heterogeneity. But I think at a population level, whether a handful of abortions are being provided legally or illegally or not is probably not ultimately biasing our overall results. And then there are a few states, obviously all of the states during the Texas period do later become ban states, but they are serving as controls when Texas's SB8 policy is in effect. And then they, in later time periods, become banned. We did not have to contend with any of the states reversing and becoming unbanned, but for work that would continue this analysis further on, you have states like Missouri that had a ballot initiative that overturned the ban in that state. And so then you'd have to think about how to, that gets more complicated. So that's an issue for another day. But so far, everyone is just going from control to ban or stay in control for the entirety of the study period. Does that answer your question? Okay. Question.
Do you think you should use the 95% confidence interval given how many outcomes you're testing? Like if you look at the outcome for women who've died, and it's like mostly around 0,
Yeah.
you can kind of squint and maybe see something, but like given you're looking at a whole, I mean, don't you worry about false discovery?
So there are multiple hypotheses. With the Bayesian approach, testing multiple hypotheses and like traditional Bonferroni type corrections aren't quite as relevant. We're doing a lot of post hoc estimation of whether these, we can say this is 90x% above, likely to be above what was expected or not. I think some researchers, we've had a whole debate with our statistical colleagues on this. Some may choose to go that route. We ultimately did not, but I respect those who would otherwise have chosen to do that. But it's a fair point.
What about just in general, like the expectation? Do you think that there would be an effect given how early the ban is during the pregnancy period, that it would affect that people could actually see what I'm saying? Like it almost seems to me like that outcome's the least likely to have an effect.
In terms of the ban is early in gestation, so how is it affecting maternal outcomes at all?
Mortality. It just
Yeah.
seems to me that's, I mean, you would, if the ban was really like, you know what I mean? That where there was a complication later that puts somebody at serious health risk, but when it's so early, I just don't understand why you would expect there to be much of an effect.
So we think that there's a few different mechanisms, and I think our the results from our fertility and infant mortality feed into supporting some of those mechanisms. For one, the additional births are disproportionately for populations that already have much higher rates, 2 to 3 times the rates of maternal and pregnancy associated mortalities, the non-Hispanic Black population, for instance. So you now have additional births that are at greater risk. So you have that kind of compositional shift. You also have a compositional shift in the health of the infants being born. Those also geared towards population that are at greater risk. And there's a strong correlation between poor infant health outcomes and maternal health outcomes. So there's that piece. And that's just on the kind of pathway leading to additional births and population compositional shifts. But then you also have documented evidence of denial of evidence-based care for people later in their pregnancy who are continuing high-risk pregnancies. And those are the sorts of stories documented through ProPublica reporting. So I think there's a few different mechanisms that I think are compelling reasons to expect that we might see increases in maternal and pregnancy associated mortality. And again, we did not see anything statistically meaningful among maternal deaths, highly underpowered to do that, but some signal we're picking up, I think, for pregnancy associated mortality. But thank you for that question.
Wrap it up there right at 1 o'clock.